Hi, I'm Phillip Hilton. I'm a second year pediatric resident here at OSU Tulsa, and I'm here to present a poster that goes over the QI project I've been working on for the last year and a half called Implementation of 2023 Pediatric Obesity Guidelines in a Pediatric Residency Clinic Setting. As a little bit of background as to why this is important and relevant, approximately 14.4 million U.S. children are diagnosed with obesity. The prevalence of overweight and obese pediatric patients in Oklahoma is 32.3%. Pediatric obesity is associated with multiple serious comorbidities if left untreated, including cardiovascular disease, diabetes, hyperlipidemia, mental health issues, musculoskeletal disorders, neurologic disorders, and sleep apnea. In February 2023, the American Academy of Pediatrics published updated guidelines on the evaluation and treatment of pediatric obesity. New guidelines emphasize enhanced screening and early intervention rather than watchful waiting. The objective for this project was to determine how to best implement the new guidelines within a pediatric residency outpatient clinic. Our team here worked with the American Academy of Pediatrics to improve the identification and assessment of obesity within a primary care medical home, with an emphasis on obtaining a comprehensive medical history. As stated earlier, this project was performed in conjunction with the American Academy of Pediatrics, specifically the Institute for Healthy Childhood Weight, and their project, Assessment and Evaluation of Childhood Obesity QI Project. 4 rounds of data collection were performed. In each round, 30 random charts were reviewed, 20 from well-child checks with the diagnosis code associated with overweight or obesity, and 10 from all well-child checks. Charts are evaluated for obtaining a complete history, screening for comorbidities, and establishing an appropriate treatment plan. This process was broken down into 3 PDSA cycles. Cycle 1, research the new guidelines, provide guideline updates to clinic providers, obtain baseline data per AAP, and identify areas of deficiency. Cycle 2, identify relevant components of an obesity-focused history per age, conduct review of clinic workflows and EHR well-child check templates to determine if inquiries into and documentation of a complete obesity-focused exam are intuitive and efficient, review results of the review of clinic workflows and well-child check templates, and identify changes to clinic workflow and EHR templates to support providers and staff to obtain and document a complete obesity-focused history. Cycle 3, identify mechanisms to update clinic workflows and EHR templates, change relevant clinic workflows and well-child check templates, obtain follow-up data to test hypothesis that changes to clinic workflows and templates will improve documentation of all 5 components of the obesity-focused history, and based on results of post-intervention review, we will continue to utilize updated workflows and EHR templates to initiate relevant yearly training for providers and staff. The results. Baseline data noted that physicians at the clinic in question obtained a complete history 30% of the time. For example, instead of inquiring about social determinants of health, nutrition, physical activity, screen time, and sleep, all components which are set forth by the AAP, physicians might inquire about only food security and screen time, but not all 5 components. After review and editing of EHR templates, documentation of complete history improved to 75%. Now we focus specifically on obtaining a complete history, but we did look at other components, such as screening for comorbidities and treatment plans, which you can see a little bit of that data on the poster as well, specifically looking at laboratory tests checking for lipids and screening for comorbidities such as sleep apnea. Conclusion. Our initial review of data, it was discovered that physicians within the clinic only obtained a complete history per the new guidelines 30% of the time. There was an initial increase, then a subsequent decrease in history completion. During that decrease, senior residents graduated and a new group of interns came into practice. There's also a large change in nursing staff within the clinic as well. After editing the EHR templates, which occurred between cycle 2 and cycle 3, A complete medical history was obtained 75% of the time. Making templates more intuitive allowed for more complete, consistent obtaining of comprehensive medical histories. This particularly is important in residency training programs that have a yearly turnover. Now that comprehensive medical exams are routinely obtained, the next steps for our group are to include increasing initiation of a patient and family-centered treatment plan, including intensive health behavior and lifestyle treatments, and improved follow-up within 4 weeks of obesity diagnosis. Thank you.